lesions in head injuries and brain tumors, those kind of things. And I hope to get I hope to get down to here and talk about the dysphagia diets a little bit today. And then when we come back, we'll do spinal cord injuries, multiple sclerosis, and strokes. Okay? We'll talk about, yesterday when you talked about it, I know that at ASLS they briefly mentioned hemorrhagic strokes and how there's really not a lot they can do. So we'll talk a little more about that, and we'll talk about taking care of the patient in the hospital once they've had a stroke. Because yesterday, I know you get enough stuff to get you up through the ER, and you're sending them to the floor. But I know I saw you going in there with her. I wondered why you weren't even. Hey, I got excretion and
mobility.
No, repro.
Okay.
I just didn't get to mobility, but I'll get to it over the weekend.
I'll look in the Dropbox and the things.
Well, I sent you an email because I'm hanging on to the sheet till Marla's done.
Okay.
Okay. So I know yesterday they talked to you about the pre-stuff and then the ER, and maybe a little bit once they get to the floor with the swallow study and stuff like that. But there's a lot more that you need to know to take care of that patient in those first weeks and then, months after they have the stroke. So that's what we'll really focus on in here. We'll kind of just review what they talked about and then move on. So that's our plan today. So we're going to talk about corneal transplants and retinal detachments first. But I need you all to tell me a couple things. So you have these old people now, older patients. Tell me what kind of visual changes this person's going to have.
Floaters.
Okay, blurry because why?
Weakening of the muscles.
Yeah, the muscles weaken, they can't make changes as fast from light to dark, and okay, atrophy. What else? What's the vision look like? Is it nice, crystal clear?
No.
Can be cloudy, and a lot of them have a yellow cast to their vision. So when they look at things, it has a yellow cast to it, like it's foggy maybe. Happens to all people as your eyes get older. But the problem comes in when you have a patient who has medications, and they're looking at the medications. I'm just going to tell you, Cozar is a little green football-shaped pill. Aleve is a little blue football-shaped pill. They're almost exactly the same size. They are the same shape. If I have that yellow cast to my vision, am I going to be able to tell which one's my Aleve and which one's my Losartan? Yeah, so they have that's why you see the patients with a lot of medications and they get them confused. It might not be that they don't know which medications they're supposed to take. They can't differentiate between which one's which and what they look like. I know last time I picked prescriptions up at Keesler, the label on the bottle went from this little tiny print like this to my name is like this big on the bottle, what the drug is and the directions.
Do you get them with bigger print or something?
Yeah, well, they're making all labels now, at least at Keesler, with large print labels so that anybody can see them. So they have some visual changes. What else happens? Cataracts. How many people have you heard of that had cataract surgery? We're not really going to talk much about cataracts in here because cataracts are very, very common. They're treated outpatient. The surgery is outpatient. You're wide awake when they do it. So they just go in there and they take out the cataract and put a plastic lens in, or a glass lens in place. So we're going to talk about corneal transplants though. Someone who needs a new cornea. I'm just making sure we didn't talk about anything. We talked about the blurred vision, the muscles reduced, elasticity, the lens gets hard, discoloration. Is someone out there? Mm-mm. Okay. Tear production. Have you had the patients at the hospital? They all have Restasis or the eye drops because they all have dry eyes. They have decreased tear production. Does that help when you have the other vision problems?
No.
It doesn't. It's very irritating to them. So we'll come back and talk about the hearing in a minute with this guy up here with the hearing. Well, let's talk about these corneal transplant patients. So we're going to talk about the vision-related disorders. The only two that are on your syllabus are corneal transplants and retinal detachments. So those are the two you're most concerned about. When you're digging through the chapters, there's like 2 or 3 chapters on ears and eyes. You don't need to read a bunch of stuff except what's under those sections. To understand it, you have to understand the anatomy of the eye. This is in your book too if you need to go back and look at it. But what we're concerned about right here is the retina, which is the blue line around the eye. It attaches to the outer wall of the eye. If you have a retinal detachment, it comes away from there and blood supply is lost to the retina. And then your cornea is this outside covering of the eye. And if it's diseased or has a process, that's what they are replacing. This is what they're replacing when you have cataract surgery. Okay? So you just have to know which part of the eye you're talking about. Have you ever had your eyes dilated and when you shine the bright light in there, you can see all the blood vessels? So that's what they're looking for, is all the blood vessels in your eyes. Very, very vascular, so you would think that it would bleed a lot, but they do this outpatient and you don't really bleed a lot. Here is your corneal problems. The cornea becomes thick and elongated. Now I'm just going to tell you, neither one of these look good to me. This is the one that's supposed to be normal when you're driving in the dark. This is what somebody who has a corneal opaquity sees. They shouldn't be driving. They look terrible. They both look bad to me. But this one is the way it is. They can't make out lights, street signs, anything like that. Because this layering over the eye right here is nice and thick and it occludes the vision so you can't really see. The way they do this is with a cadaver cornea. So that's why they ask about donations of eyes. They take the cornea from the cadaver, the dead person, and they cookie cut out right here the piece of the cornea that has to come out of the patient. They use that same cutter and cut the shape out of the cadaver eye, and then they graft it into the eye. So what kind of problems do you think the patient could have?
Tissue rejection.
Tissue rejection, that's the biggest one. There's not a lot, like a patient knows they need this procedure, but there's not a lot of time between when they get the cadaver eye and when they do the procedure, so that you gotta do all your teaching up front and have that patient ready to go when an eye becomes available. This is what it looks like when they put it in. It really is like a cookie cutter thing, and they put it in place, and then it's all sutured in. So, just off the top of your head, what kind of things do you think you might want to tell your patient when they go home? Yeah, don't be rubbing your eye, because you don't want to undo the sutures in that
Can they
cornea.
see those sutures? Are they in the way of their vision?
Not really, because they're all along the outside edge, so that they're not really going to see them through the pupil. They will dissolve. What else might you think you need to tell them? Okay, eye protection. That usually, if it's one eye, they send them home with an eye patch over that eye, and tell them that, especially when they're sleeping, because you know when you're sleeping, you don't know what you're doing. Especially when you're sleeping, sleep with the eye patch on. What else might you want to tell them? Eye drops. So this patient's going to actually have eye drops to keep the eye moist, and they're going to have antibiotic eye drops because the risk of infection. Do you want to add, or are you stretching, fixing your hair? Person's fixing the hair for us. What about signs of infection? What do you want to tell them? What are they looking for? Okay, drainage. It's going to itch, because you ever have something that's healing up and then all of a sudden it's itchy? So I'm going to warn them not to rub their eye and scratch their eye, but the drainage from it, if you wake up and your eye's matted shut, like when you have pink eye, or if you notice that there's any kind of yellow or greenish drainage, you need to let somebody know about that. When you teach them how to put eye drops in, what do you need to teach them? Yeah, don't touch your eye with the tip of the bottle, because you're transferring bacteria possibly from one surface to another surface. So you gotta make sure they know how to do eye drops. Can everybody do eye drops by themselves? No. So if you teach a family member, what are you gonna teach them? Don't touch their eyes, and make sure that When they're pulling the eye up, it'd be best if they wore a glove, because they don't want to introduce any bacteria into their eye, but to pull the upper eyelid out of the way and put the eye drop in. So just a couple things. We're going to talk about some more things, but we're going to talk about them all together because they're all the same for your post-op patients. But that's your little cookie cutter procedure. See why I picked this easy stuff today? Because I know you're tired from yesterday. I went to
So
it
if they were matted shut and stuff like that, could you tell them to put like a little warm cloth?
Yeah, a little warm compress just to clean it off, but you need to let the doctor know that, you know, I have this drainage from my eyes. But you don't want them doing any vigorous rubbing of the eye. And I also would tell my patient to use sterile gauze instead of just a washcloth out of the cabinet, because you just don't know if it's clean or not. So there's your corneal transplant. Where's this done? It's outpatient. The patient's wide awake. They numb their eye with, you wouldn't be awake?
Oh, no.
Nope.
Yeah, they actually numb the patient up with a whole bunch of numbing medication, and they're wide awake. They might get a little bit of Versed to kind of take the edge off, but they're still wide awake the whole time. And the doctor will tell them to move their eyes either to the right or the left, and they can still follow directions. So, huh? Well, I mean, I don't know if you actually see it. No, you can't close your eyes. I wish I had a picture. I should have put a picture in there. They actually take it's like a metal retractor. They hold it open so you can't close your eyes. But yeah, it's a metal retractor for the eye. It keeps it open the whole time. No chance of you closing down on their instruments. So this is your retinal detachment, and this is right here where it comes apart. So now there's no blood supply. Is this an emergency or a non-emergency?
Emergency.
It's a medical emergency. So if it happens on the weekend, they need to go to the ER so they can get an optometrist to come see them. Because the longer this area right here goes without blood supply, the more permanent the damage is. Yep.
So my best friend had his retina detached in high school, and he's had 13 surgeries since, but he just woke up blind. Like, he literally woke up and couldn't see in that eye. And then when he got there, they were like, thank God you came in, but you still may lose your eye.
Right.
So, I don't know, it's probably crazy. But
Yeah.
we were like 16 years old, and he was like, yeah, I'm
Was he
worried.
in sports or anything that he
He
got
played
hit?
baseball, but he didn't get hit or anything, and he just woke up one morning and it wasn't good to see.
Yeah, my dad had a detached retina, and he just, all of a sudden, this cloud came down over his eye, and couldn't see out of one eye. Of course, you know, when you're 80 years old, that's really nothing. He did go to the doctor, but, you know, but the longer it goes, the less chance they have to repair it. The other thing is, people who've had cataract surgery have a higher incidence of having retinal detachments. So if your patient has had cataract surgery, when they're discharged, they tell them, these are the symptoms that a detached retina would have. You need to come back if that happens, because they have I can't remember what percentage it is, but it's like 45 to 55% higher chance of developing a detached retina. So this is what it can look like. They can have lots of lines and squiggles. They can actually have like a curtain that just covers the eye and blocks the field of vision. So it can be different things for different people. Do people have floaters all the time? Like old people? They'll tell you, I have this one floater in my left eye, I see it all the time. And once you're checked out by the doctor, that's normal. But all of a sudden, if they develop like a whole bunch of floating things, or if they notice that I can't see out, my peripheral vision on that side is gone, they need to go have that checked out immediately. But that gives you the little picture of what it could look like. There's two ways to fix this, depending on how bad it is. If it's very, very severe, they'll use this scleral buckle, and it's like a rubber band, and they put it around the eye to hold the eye and the retina up against the eye wall, and it'll reattach itself. But 16 surgeries on your friend's eye, because once it happens, it can happen over and over and over again. So once it happens, you're more susceptible to it.
It was like every December, or like every December, and then at June sometime he'd have to have like another minor one.
That's weird.
It
It was crazy. But they do tell you, once it happens once, it could happen again. Your chances go up, your risk factors go up. If it's small, they do this right here. They either use this, it's oil or some sort of emulsion stuff that they put in there. And it pushes, see how it pushes the retina back up and eventually the space will close? If you have the buckle, it's holding the eye against the retina. If you have the gas, what do you think you need to think about if your patient has the gas bubble or the oil bubble? Pressure, what do you mean light? Tell me what you mean. Okay, flying's an issue. If you have a retinal detachment and they fixed it with this gas bubble thing or the oil bubble, you cannot fly till that is resolved or removed by the eye doctor because the increased pressure in your eye with that extra bubble right there. Positioning is the big thing with the gas bubble. Yeah, because think about it. If the tear is up here and you put the gas bubble in and I'm upright, the gas bubble is pushing up against where it's supposed to be. If the tear is back here and I'm upright, the gas bubble is up here. Is it doing what I want it to do? So your patient they have to be taught wherever the tear was and where the gas bubble is supposed to be. A lot of them end up laying face down like that until it's resolved, and it can take a couple weeks to resolve. So for the most part, the majority of the time, you're face down because you want the gas bubble pressed against the back of the eye. So positioning with your patient is a big deal if they have the gas bubble fixed for the retinal detachment. Does that make sense?
Yeah.
The band isn't a big deal because it's pressed down on your eye. So if I want to take care of them post-op, you told me I don't want to rub, I'm looking for infection. We talked about positioning and flying. Let's talk about the other things that you might need to know if you're going to send your patient home with one of these procedures. Because they're both done outpatient, so they're going to spend a very short period of time with you in the recovery room. And you're really going to be teaching their spouse or significant other, because if they had versed, they act like they know what you're talking about.
They don't know.
But they don't. They don't remember. Okay, if you have multiple drops, so moisture and antibiotics, sometimes if you have the transplant, what other kind of drops might you have? Steroid drops. You have to have the 5-minute space in between the drops so that they have time to do what they're supposed to do, because you don't want to mix them all together. What else do you think you want to think about? You talked about the eye patch already.
Activity level.
Okay, what kind of activity level?
You're not supposed to like
They're gonna be
stay
face
contact
with their face
sports.
down.
You're not supposed to do very much.
Yeah, they're supposed to be chilled out, no straining. So,
No rapid eye.
okay, no rapid eye, we'll talk about that in just a minute, keep that in your head, Denise. So, the straining activities, so I like to garden. I just had a retinal detachment. Should I be out there in my garden bending over things? Because every time I bend over, what am I doing to the pressure in my eye?
Increasing it.
Well, you know, I like to play with my grandkids too. And I'm gonna pick them up and we're gonna go swing and stuff. Can't do that. Any kind of activity that increases intraocular pressure is a no-no.
What you do is give them a stool softener.
Yeah, you might want to give them a stool softener, because if I'm constipated and I'm straining, the intraocular pressure is increased also. So yes, a stool softener is a good thing. Denise said no rapid eye movement activities. So we don't want them to do things like read. They really don't like them to watch much TV at first, because you know your eyes are always, you don't know it, but your eyes are always moving. And so anything that does rapid eye activity. What if I said, oh, I love to embroider. Can I embroider while I'm healing?
Nope.
No, any of that close work activity is a no-no. What'd you say? What'd somebody say over there? What'd you say?
Not really. What about light? They won't be like in low lights.
They don't have to be in low light, but I'm gonna tell you, any kind of procedure like that, the light's gonna bother you. That's why when you leave the office, they give you those funky little prescription glasses to, or sunglasses to wear.
What about REMs? Do you not want
Yes, they can sleep. I don't want them to strain their eye doing anything, you know, like studying. I don't want
What
them to
kind of activity would you suggest to the family if it's?
sit around, sit around and do nothing. Yep. Like I know when my husband had his done, he sat around and with the TV on, but he had his sunglasses on. He wore his sunglasses the whole time and he really wasn't watching it. He has his eyes closed.
They didn't even want us around.
Listen to the radio.
They recommended to Hayden that his friends not come over for like a week or two. Cause they didn't want us, like too many people there and him to be like
Right.
overstimulated.
Right. Because it really takes time to heal. And so, yeah, they don't want you, overstimulated. Let's see, you talked about infection and the manifestations of infection. So if I have visual acuity changes or eye pain, is that a problem?
Yeah.
Yes, because these procedures aren't particularly painful. So all of a sudden, if I wake up and I have pain in my eye, that is a problem, and I need to let my doctor know about it. Also, if my family member notices just walking by, my pupil's super big, it doesn't constrict, that's a problem. A pupil that won't constrict is a problem the doctor needs to know about. Because when they're in there doing that, which cranial nerve could they have affected? Which ones? 2, 3, and 6. Make your eyes do tricks, yeah? So 2, 3, and 6, if they're in there doing any kind of procedure like that, they could have irritated the nerves, the cranial nerves in your eyes. So if your pupils no longer dilate, that's actually cranial nerve number 2, and they need to know about that. We talked about flying till the gas bubble's resolved. We talked about local antibiotics. The patch. Does the patient have to wear the patch all the time?
No.
When they sleep. After the first day, only when they sleep. And that's because when you're sleeping, you don't know what you're doing, and people rub their eyes in their sleep, or you could turn and hit your head on the, I don't know, drug pillowcase or something, I don't know. But they want you to wear that eye patch. How do they wear the eye patch?
They put it on the part.
Well, okay, yeah, if you're lucky enough to get the pirate one with the strap around it, you can do that. What kind of tape am I gonna use?
Paper tape.
The paper tape. I don't wanna use, duct tape or, well, exactly, but I don't wanna use like that silk tape that's real sticky. I want just paper tape, enough to protect it, but not to rip my skin off. What about ice? Ice or no ice?
Yes.
Who said yes?
No.
Okay, they do not recommend ice because vasoconstriction. If I need blood supply to my new corneal transplant and my retina, and I put ice on it and constrict the vessels, am I getting good blood supply? So they don't want ice put on it. Bending from the waist, how heavy objects should they lift?
Less than 10 pounds.
Less than 10 pounds. No running, no dancing, no rapid jerky head motion, things like that. So video games, that's a no-no. Because, yeah, no, video games, no video games. Let's see.
So could they put like any kind of heat on it, or would they not recommend
They don't recommend heat either. It's not painful. It is not supposed to be painful.
So if it is.
So if it's painful, you need to call a doctor, because it is not painful. Decreased vision, floaters, things like that, they need to be reported to the doctor. And graft rejection. Somebody said about graft rejection, if you're doing a corneal transplant. What do you think their vision would be like if they're rejecting the graft? Yeah, the vision's gonna get cloudy. They're not gonna have clear vision. Because when they get that new cornea, the vision's gonna be super clear. Then all of a sudden, if it starts becoming cloudy, rapid onset, there's a problem there. So they're gonna need to let the doctor know about that. If the cornea becomes cloudy, that's when they use steroids and immunosuppressant drugs to try to stop the rejection of the graft. Does that make sense? Go ahead. Oh, yeah. Mm-hmm. Yeah. Well, no. They're not gonna, they might give you some steroid eye drops. right off the bat because of the inflammation. But they're not gonna start you on any kind of oral steroids until there's a risk of a rejection. Yeah. So, do you think that you could discharge somebody from the surgery center with a corneal transplant and give them some decent directions? So you'd have to see them again in 2 days. Okay. What's that? And then to see you, right, exactly. We don't like them to come back. So, we have to talk about a hearing related disorder too. So tell me about old people and their hearing. How does it change?
What hearing?
They do say huh a lot. Do you ever walk in the patient's room and the TV is like full blast?
Gosh.
You're like, I'm trying to listen to the noise now.
And they're sleeping.
I know, exactly. And if you turn it off, they'll wake up immediately. But you say, could you turn the TV down just a little so I can listen to your lung sounds? You know, because it's so loud you can't hear it. Why does hearing decrease as you get older? Yeah, the tympanic membrane when you're little or young is very flexible, and as you get older, it gets more rigid, and so they can't hear the same sounds. Which sounds can they not hear? High pitched or low pitched? High pitched. So they can't hear when they listen to music and stuff, and you're hearing all this funky stuff in the background of the music. Old people don't hear that. You know, oh wow, listen to those trumpets in the background. They're like, what trumpets? I don't hear that. But they can't. I'm serious. They can't hear certain letters too when you talk to them. P's, S's. I have them written down somewhere here on my paper. But they can't distinguish between the difference in sounds. So they let me see, I wrote it down. F, S, P, A, and SH. Those are the ones they can't hear. So they can't distinguish what you're saying. What about wax in their ears?
FSPA.
The S, the P, PA, SH, and F as in fish. What about the wax in their ears? They have more cerumen in their ears, and it builds up around that rigid eardrum, so that impedes their hearing also. Do we yell at our older people? Some people do. I mean, some people do just go in and yell, and you'll have somebody else say, oh, I can hear perfectly fine. They're eating and they hear fine, but because they're old, we like to yell at them. But not old people can't hear, but it is very common that they do have some hearing disorders. Do they like to wear hearing aids?
No.
No, because for a couple of reasons. They're uncomfortable, I guess, I've never had one. But, they don't want anybody to know they can't hear, so they would rather just pretend that they can hear, than for you to see a hearing aid, you know? And a lot of people have gone so long with this impaired hearing that they get a hearing aid and they can't stand it. It's just too much. I bought my mom hearing aids for her birthday 2 years ago, and she wore them a couple of times.